Hey, Juliette, welcome to the show.
Hi, Brittany. Thanks for having me.
Absolutely. Where are you calling in from today?
I'm calling in from right outside of Boston where it's about 50 degrees. The leaves are turning all different kinds of colors. So it's pretty, but it's cold.
Well, that sounds like the like the light before it starts to because I grew up in Northeast
Yeah,
US, and it gets dark and it gets
exactly.
cold, and I personally always found myself getting sadder around the holidays, and I don't
Yep.
know if it was just because the holidays, but it was also because the sun wasn't out and it was cold. And I'm really excited that we are actually going to be talking about mental health. It's in time for, I think, a season where people a lot of times feel sad or anxious, or they're losing sleep. So let's talk about that at a really pertinent time. Is that something that y'all see, is that during the holidays people get sadder?
Yeah, absolutely. I mean, there's an actual mental health diagnosis that is seasonal affectiveness disorder, or I'm sorry, seasonal affective disorder. And so, there are a number of people who actually struggle from clinical levels of symptoms of depression and anxiety because of the low levels of light that people get and sunlight that people get. But beyond that, even if somebody is not, having a clinical diagnosis, absolutely the lower levels of sun, the stressors around the holidays, around, traveling or preparing a dinner for your family, or even interacting with your family,
Mm-hmm.
who, most of the year you might minimize communication with, all of those things can come together to really impact people's mental health and their sense of well-being and stress. And then I also think that because of the pandemic, there are a lot of barriers to people being able to see their loved ones and spend time with their loved ones during the holiday. I think it's gotten better this year, but there's still a lot of isolation and loneliness that can happen around the holidays as well. So at Big Health, where I work, we work with a lot of clients, and we certainly have a lot asking for webinars around, how to manage stress and anxiety around the holidays, around this time of year.
Well, we're definitely going to get into big health and what it is and how you guys help people. But I have one more quick question about the
Yeah.
seasonal disorder when you get sad because the lack of sun. Is there actually scientific evidence? Like, are we actually a little bit like plants? Like, why is it that the sun makes us happy and the lack of sun makes us sad? Do we know biologically how that works?
I think someone knows biologically how that works. It's not me, but there certainly are treatments that people use sometimes, like having the those blue lights
Yeah.
that basically, like, bring whatever's in sunlight that helps with our mood, and you can have it in your room and like sort of take advantage of that, and that can have some positive impacts on mood as well. But I think overall, the other part is that we tend to stay in more when it's cold outside or when it's dark outside. And so we may be getting less physical activity, which can also affect our mood. And, we're not able to necessarily do all of the things that help us, stay in, help relieve our stress and things like that during the winter when things get colder. So, there are a lot of things I think that we can do in terms of like figuring out, what's my spring and summer plan for coping with my feelings, and my mood, and then what's my like fall winter plan, because sometimes we have to switch it up depending on where we live.
Do people actually switch their medications based on the seasons?
Sometimes I know that there are at times people may start a medication or only take a medication like an SSRI for like mood support, during the fall and winter, and then may stop taking it like in the spring and summer. But yeah, I mean, certainly the holidays are a time when people may be more likely to be going to their doctor for help, experiencing stress, having trouble with sleep, and all of those things.
Well, let's talk about you. How do you know these things? Who are you? So tell us about your background. What are you trained in? And then a little bit of your personal journey. How did you end up working here for Big Health?
Yeah, totally. So I am a clinical psychologist. I trained at Washington University in St. Louis for my PhD in psychology. And there I just learned all of the ins and outs of clinical psychology, so mental health disorders, and how to treat them. And so that's where my training lies. And then after that, I did an internship at a community mental health center where I did 100% clinical work 100% of the time, which was really fantastic because during my graduate school experience, I was doing some clinical work, but also a lot of research as well. So I had 100% clinical year, which was really eye-opening in terms of I worked with a very low income, seriously mentally ill population that had very limited resources. And it just opened my eyes to a lot of the gaps and dysfunction within our current mental health care system. And then after that, I actually was at the VA, the Veterans Administration, for a few years, working on research that really focused predominantly on the impact of discrimination on the mental health of veterans of color. And so throughout my entire educational life and career, I've focused on racial and ethnic health disparities and how different factors like different types of stressors like trauma and discrimination and life events can contribute to racial and ethnic disparities in mental health outcomes. And so that's what a lot of my research has focused on. And then at the VA, I was able to hone in a little bit more on understanding trauma and the ways in which discrimination and racism and other minority stressors can actually impact trauma and PTSD in different ways. And so that's where a lot of my research focused. So that's sort of like my professional background and where my expertise lies. In addition, I also, was heavily trained in delivering cognitive behavioral therapy for mental disorders, which is a form of therapy that really focuses on changing behaviors and changing thinking patterns that are perpetuating or maintaining a mental disorder, a mental illness. And so I'm heavily trained in that area. And so for me, evidence-based care, mental health care that's based on a significant research evidence base, as well as culturally responsive evidence-based care are two of like my major passions, and where I've spent a lot of my, especially educational work. So that's me professionally.
Mm-hmm.
Personally, I'm a woman of color. I'm a Black woman. I grew up in the San Francisco Bay Area, moved to Boston for college. I went to Harvard for my undergrad, and then moved to St. Louis and came back. I have an 8-year-old and an almost 5-year-old. So that's lots of fun. And so I'm a working mom and try to get back to California to visit my family whenever I can. And yeah, so that's kind of my overall background. And then my journey to Big Health was really, I was in this stage of my life before I joined Big Health. So I joined them earlier this year as director of medical affairs. And we can talk more about what Big Health does in a moment, but I was in a place where I was looking for something new. And I had been asked by Big Health to consult with them in the summer of 2020. They really wanted to ramp up their mental health equity, focus. And so I was brought in as that expert, and I loved working with them so much that when this position opened up that I was a good fit for, I jumped on the opportunity to join Big Health because we really have scalable solutions for mental health that I was really passionate about that can fill gaps in our current healthcare system.
So exciting. And when you're doing all of this work in equity in mental health care, did you find that there was a gender and sex gap as well as racial?
Yeah, that's a great question. So a lot of my work ended up really focusing on the intersections of gender and race and ethnicity, because we know that, of course, there are different ways in which, gender identity is shaped and different ways in which people who are born male and people who are born female or assigned female at birth or assigned male at birth are sort of socialized and treated in our society. And that is true across the range of race and ethnicity, but within different racial and ethnic groups, it can be different the way that people are socialized.
Yeah.
And so I definitely looked a lot at some of the similarities and differences between men and women in terms of the impact of discrimination on mental health. And so always took an intersectional perspective when doing that work to really understand not only what's going on within the Black population, but like how that differs perhaps between men and women. Yeah. In addition, at the VA, I was a clinician within the women's trauma recovery team there. And I also worked in the women's health sciences division. So a lot of my focus was really on, understanding women veterans who are really at a sort of very small and underserved population, and understanding women veterans of color in particular and the specific needs that they were looking for in terms of their mental health care. And so in that vein, I was able to do some racial stress and trauma groups, which was an innovative intervention that was developed by a few clinicians at the VA. And I was able to bring it over to my VA and do something that hadn't been done before, which was offer these groups specifically for women identifying veterans. So it was an all women's group where they could really share their experiences, not only as Black people or people of color, but also as women, and the ways that those identities intersected along with their identity as a veteran as well. And so I absolutely see some of those differences.
It sounds like that would be obvious that they would have a women's only group, but that was innovative.
Yes, it was.
Oh yes. My
God. Well, it's hard among veterans, like, there's a small proportion that are women. And so, and they're all spread out across the country. So it's always kind of challenging to like get women all in one place, women veterans. But what I loved about the Boston VA is that they have a dedicated women's trauma recovery team in the mental health service. And they have a dedicated women's health, like medical service as well. So there's a lot of really awesome and innovative things. And I know it sounds funny that it's innovative to have women's health, but at the VA, which was really created for, men, because that was the majority of the veteran population. It's been very innovative to create these services that are specifically for women and their needs.
Interesting. Well, tell us, what is Big Health?
Yes. So at Big Health, we're a digital therapeutics company for mental health. And we focus specifically on sleep and anxiety right now, but sort of sleep and mental health generally. And so what we do is we provide safe and effective non-drug options for mental health care. And what that means is that, so a digital therapeutic is clinically evaluated software that leads to health outcomes. So what that means is that our digital therapeutics are backed by an extensive research base. So we have 13 randomized controlled trials on our therapeutics, which is unheard of in the digital therapeutics field, and even unheard of for some pharmaceutical drugs as well. We have over 28,000 people who've participated in our studies, and we have like over 60 publications on our therapeutics. And so we have a very
work. I love it.
Exactly. That like it's all about the research. It's all about the clinical evidence, because at the end of the day, you can put something out there, but if you can't show that it works, what use is it? And, not only show that it works, but also show that it's safe and that it won't lead to harm. And so that's the work that Big Health has really put up into what they're doing up front, so that once we put things on the market, they've already been evaluated for safety and efficacy.
And so you guys are targeting anxiety and insomnia as like the biggest ones for right now. And they each have like a different app. And what are those names?
Yeah, so we have Sleepio for insomnia. That was our first digital therapeutic. It's been around for about 10 years. And it is basically the translation of cognitive behavioral therapy for insomnia into a digital format. So what it does is that, because digital therapeutics are fully automated, so ours are purely software. There's no therapist involved. There's no human being involved. Yet we're able to deliver the therapy, cognitive behavioral therapy, effectively at scale and consistently, which leads us to over 70% of people who use our therapeutics getting better and actually getting to non-clinical levels of symptoms. And so Sleepio really focuses on insomnia. It focuses on all the tools and techniques that have been shown to work for treating insomnia. And then once we translated it into the digital format, we actually study within that digital format whether it's working and leading to outcomes. So that's Sleepio. And so that's available via desktop and app. And then I'll say a little bit more about how we get our therapeutics out to people in a bit. But Daylight is our other therapeutic, which is for generalized anxiety and worry. And that therapeutic is very similar to Sleepio overall in terms of it's fully automated. But with Sleepio and Daylight, you have sort of an animated expert guide who takes you through. So you kind of have like an animated therapist. It uses AI and screening measures to personalize the each session or each module to the individual. And Daylight is super cool. We partnered with experts from Radiolab and Pixar to create like a really engaging animated experience. And so some of the characters or monsters might look a little familiar to people who, are into Pixar. And then we had actually one of the producers from Radiolab is the voice of the digital therapist in Daylight. Yeah. So very cool and very engaging. And I think sometimes people think about digital mental health solutions as kind of like, oh, I'll go in and like watch a video or a lecture and read and, kind of boring, not super engaging. But our therapeutics are very engaging. And it really feels like you're going to a therapist's office to learn skills. So of course it's recovery oriented. They're not sort of talk therapy oriented, like support oriented, where you go in and talk about your relationship problems. There's that's really important. But what our therapeutics do is really target these specific mental health conditions and then provide people with the skills and techniques that they need and guide them through using those skills to be able to actually address the root problems that are maintaining their mental health condition and then help them get to recovery.
So is insomnia considered a mental health condition?
Yes, it is. And it's great that you asked that because I think a lot of people don't think about insomnia as a mental health condition.
Yeah.
And that's part of the reason why Big Health started with insomnia, because oftentimes people are a lot more comfortable talking about problems with sleep or falling asleep than they are talking about, I'm feeling depressed or I'm feeling down or anxious. And so we saw it really having this insomnia digital therapeutic as something that could bring a lot more people into getting sort of treatment for mental health or kind of a foot in the door for them, because insomnia and we don't even refer to it as insomnia in our therapeutic, we call it poor sleep. In order to destigmatize that feeling of like I'm being diagnosed with something. And so we saw that as potentially being something that people would be more willing to engage in because it's a little bit less stigmatized. And that's absolutely been the case. The other thing about insomnia is that yes, it is a mental health disorder, and it's also very co-occurring with a lot of other problems, including other mental health conditions, as well as chronic health conditions. So things like diabetes and hypertension and cardiovascular disease and a lot of those chronic illnesses, there's a lot of overlap with insomnia. And so treating insomnia can potentially have an impact more broadly on overall health.
How do you define insomnia? To me, I'm like, okay, you struggle to go to sleep, but maybe that's not actually the definition. What is insomnia?
So the insomnia is to get the actual sort of, clinical diagnosis. I can't rattle off the top of my head all of the symptoms, but it's really basically you're having trouble getting a certain amount of sleep for a certain period of time. In which you're struggling. So if something happens and you have like a week or two where you're not having great sleep because, I don't know, let's say you have somebody visiting you from out of town, that's not insomnia. Insomnia is really this longer term kind of chronic problem that lasts for a period of time that really interferes in your ability to function. So again, another example, if somebody's I remember President Clinton at one point was like, I only get 4 hours of sleep a night. That's all I need. That may be true for some people. That's not insomnia. If it's not negatively impacting your daily functioning, but if it's negatively impacting your daily functioning, then it starts to get into the area of insomnia. So we define it by sort of like how troubled your sleep is, and then how much it's affecting your functioning, and then how long that has been lasting for you. And so what we do in Sleepio is when people first sign on they fill out a quiz that's like, what's your sleep score? Where you answer a bunch of questions that are based or that are a clinically validated screener for insomnia, and then you're given a sleep score. And so anything in our therapeutic, like under 5 is probable insomnia, and those people would benefit from the therapeutic. And so we're able to sort of give people, when they use Sleepio, give them an idea of sort of what level their sleep is at, but we don't diagnose or anything like that.
Yeah. Does insomnia disproportionately affect women?
It does. Yeah.
Do
Yeah.
we know why?
That's a good question.
I wouldn't be surprised if we don't know why. There's a lot of things where like disproportionately affects them, not sure why. So
yeah, I mean, I certainly have speculations.
uh-huh.
But I think there are a lot of additional, so when I think about mental health, I really think about stress as being one of the main drivers of mental health conditions. Stress that gets to past a point of one being able to cope, right? So I think that women oftentimes in our society, and like, I'm not even bringing intersections in here, but women of all ages, races, genders, all ages, races, sexual orientations, take on a lot of caregiving responsibilities, whether that's for children or aging parents, um, uh, have to do a lot more of the sort of housekeeping kinds of work and childcare. They also have the invisible kind of emotional labor that they experience. And so women are more likely to experience those things than men, even if they're working. So even if a mom is a working mom, she's still oftentimes, the majority of the time, women still take on the majority of the caregiving responsibilities, even if they're working. And so I think because of a lot of those stressors, it can lead to disruptions in sleep. And we know that some of the things that maintain poor sleep are things like some of the sort of what our minds are doing when we're trying to go to sleep. So for a woman, if she has to meet a deadline, she has to make sure she makes the parent teacher conference, get her kids to school on time, make sure they have lunches, make doctor's appointments, make sure groceries are gotten for the day. I'm talking really about a mom here. When she lays down to go to sleep at night, she's got all these things running through her head of like, I have to do this, I have to do this, I have to do this. And so, that can really disrupt sleep. And then there may also be some biological aspects, of sort of that also may disrupt sleep in different ways. That's not my area of expertise, so I'm not even going to go there. But I think just thinking from the standpoint of stress, can understand the ways in which women tend to be under more stress. And then if we think about women of color, for example, we get that even more heightened. And so, we see a lot of disparities, racial and ethnic disparities in poor sleep as well.
Is that something that is, we notice there's a lot of discrimination in women's health around not believing women's pain. And so do we find that like women of color are told like, oh, you can't sleep, that's like not real, or, are women of color a little more hesitant to bring up their sleeping patterns or things around that?
That's a great question. I don't know if I've seen any research around whether women of color are more hesitant to bring up issues with sleep with their doctors, but there are overall patterns of disparities or disproportionate sort of prescribing and support for women of color for their problems that they bring up. So whether it's pain, whether it's sleep, whether it's depression, whether it's anxiety, Black women are less likely to be provided like a referral or a prescription for those problems. And we see that across different racial ethnic groups. So it's not just women, it can also be men. And so we definitely see that, there are some problems and some disparities that we need to better uncover and understand, so that we can get people the help that they need when they need it. I think that Black women are less likely than white women to talk about their mental health and bring it up, or women of color, because in many communities of color, there is, stronger stigma around help seeking for mental health problems. And, a lot of that is because of ongoing and traditional like distrust in the mental health care system and the healthcare system in general. There's fears of being labeled with a stigmatizing identity like a mental health condition. There are fears about being medicated as well. And so there are a lot of there are a lot of fears and lack of trust in the healthcare system among communities of color that also get in the way of people seeking out the help that they need. So we know, like, for example, like 1 in 4 Black Americans who need mental health support or help do not receive, or only 1 in 4 receive it. So 3/4, 75% of Black Americans who need mental health support do not get it. And so we see these disparities play out in the real world.
Do you think that digital therapeutic is a solution to that disproportionate treatment?
Yeah, I think digital solutions fill a really crucial gap in the mental health care system. So the way the system works right now is that essentially, especially since the pandemic, there's a huge demand for mental health support. People have been isolated for months and months. People have been experiencing high levels of uncertainty and anxiety around the pandemic, stress about going back to work, about their kids going back to school, even some of the tension within communities around mask mandates and vaccinations. All of these things on top of what happened after George Floyd's murder and the additional stress that brought to the surface for people of color, especially, we've seen a really huge increase in demand for mental health care services. But the problem is that we don't have enough actual providers to meet the need. And
when you say providers, I'm sorry to interrupt, but do you mean like therapists and counselors or psychiatrists that prescribe drugs?
Everything.
All of it.
Everything. Okay. Yep. Whether it's psychiatrists, psychotherapists, counselors, all across the board, we don't have enough people to meet the need. And even as it stands right now, clinicians are extremely overburdened. They have huge caseloads, and so they're burning out too, right? And then we have turnover. So the system as it stands is really not tenable, and it's not going to be able to meet the full need of the population. So if somebody wants a mental health appointment, they're likely going to have to wait at least a month or 2 before they can see someone. But if they need help now, really
you usually do when you're that sad to reach out.
Yeah. And so, but if they need help now, really their only option is to go to their PCP and get a medication.
Yeah.
Right. Especially when we think about sleep and anxiety, we have these really strong useful tools, but they're not meant to be long term. They're meant to last maybe a month or 2 at the most, and then people are supposed to get off of them. But the problem is that if that medication is taken and it's not backed up with some kind of evidence-based intervention, that person is less than 50% of those individuals recover.
Wow.
And so that's where we really see this tension. So where big health comes in with digital therapeutics, and what I think is really, really promising for the field and for our ability to really help people, is that because they're entirely software based and don't require human beings, yet still lead to these great outcomes, over 70% of people getting better, they're highly scalable, right? So just like drugs, you can produce massive amounts of pills and get them to people very quickly. The same with digital therapeutics. It's just software. So anyone can download it onto their computer or their smartphone and be able to engage. And so that means it's very scalable. You don't have to wait for an appointment. You can access it 24/7. So it can fit into your lifestyle. So other barriers we see to engaging in mental health care are like, scheduling. So if somebody has like a full-time job, you don't necessarily have an hour every week to do a telehealth appointment or drive across town to get to a therapist. Or if you aren't sitting at a computer all day, like, and really all you have is your mobile phone, you can pick it up out of your pocket, engage in a technique, and sort of use it to deal with anxiety in the moment, for example. So if you're like about to have a big meeting and you're feeling really overwhelmed and anxious, you can pull out the Daylight app, go to one of the technique, but sort of say how you're feeling. They'll be like, hey, why don't you try this technique? You can try that technique in the moment, and it can help you manage that anxiety in the moment. And so what these therapeutics do is they're highly scalable. So we can reach a lot of people who aren't in the mental health care system or who are having a hard time navigating it, or who don't want to interact with it because they don't want to talk to a human being about their problems, right? They don't want to share all their personal information with essentially a stranger. So sometimes it's easier and more appealing to get onto a digital therapeutic where there is no other person and you can just learn the skills that you need to be able to manage whatever condition it is you're struggling with.
And I can imagine there's much more negative side effects of taking drugs than there is a digital therapeutic. Can you talk to us about side effects of psychiatric drugs?
Absolutely. Yeah. So there are significant side effects of psychiatric drugs. So I'll talk about, in particular, hypnotics, which are things like Ambien, and then benzodiazepines, which are medications like Xanax. Those are very fast acting medications that get you to sleep and get your anxiety down right there in the moment. However, they also have the strongest black box warning from the FDA because of their safety profiles. So for example, with Ambien, I think a lot of people have heard like different, like really wild stories about people like being on Ambien, waking up and driving around town and having no memory of it. So that's kind of an extreme case, but certainly there are more common issues with like next day drowsiness. So if you think about somebody who's getting up to work, to drive to work, to then work in, you know, on a production line, for example, that person cannot be groggy, or it really increases their risks for accidents. And so while it does help that person sleep at night, they're still experiencing that daytime drowsiness. And so that's having an impact on them. You know, with benzodiazepines, there are risks for, you know, it can interfere in cognitive, you know, abilities, like your ability to think clearly and concentrate, can also make you very drowsy, can lead to, you know, I knew somebody or know someone who took a benz or an anti-anxiety medication and had to sit for 30 minutes for their blood pressure to like recalibrate before they could get up and like go to work. So, you know, there are a lot of side effects to these medications that, you know, can be really, can be dangerous, but even the common side effects that aren't as severe can impact people. Everyone's different, so it may impact everyone differently. And also, you know, the other problem is that people may start taking a medication, experience side effects, and then stop taking it. And then what are their options for dealing with their condition? You know, really starts to dwindle. So, you know, what we're able to do on our digital therapeutics through our 13 randomized controlled trials have observed 0 serious adverse events. And so, you know, our side effect profile is low to minimal. And so, so we're able to deliver the scalability and the consistency of drugs without the side effects and downsides of drugs.
Yeah. And, you know, we were talking way earlier about like how innovative it was that the VA had a women's only group for mental health support. What about in clinical trial research for psychiatric drugs? Because we do know that Ambien was being prescribed to women at the dose that men should take. And it led to this giant, I think it was a lawsuit where all these women were getting in car accidents the next morning. And they figured out that women metabolize Ambien slower, so they need a lower dose. But it took like 20 years to figure that out. Do we have other case studies in mental health where there's a psychiatric drug that, you know, has mostly only been tested on men, but then given to women or anything like that?
So I think it's kind of a common, it has been, I don't know if this is changing. I'm not a psychiatrist, so I can only speak so much to sort of the psychiatric field and how they're doing clinical trials and pharmaceutical companies. I think it's been a longstanding issue that men are more represented in trials of medications. And so, you know, that problem in terms of the biological, like metabolism and things like that, have happened across a lot of different types of medications. And sometimes, you know, because there may not be great representation of women in a study, then we're not able to see those side effects right off the bat. And so then, yeah, it takes years to finally see what's going on, because you're not in a controlled environment anymore. And once those drugs are out on the market, you're not getting, feedback or measuring outcomes or anything like that, right?
Yeah.
In terms of where I see it in sort of my arena in clinical psychology, is that women tend to be overrepresented in studies. Maybe not overrepresented, but well represented in studies, because women tend to be actually be at higher risk for many of the mental health conditions that we think about, like depression, anxiety disorders, insomnia. And so women are more likely to suffer from those conditions, or at least admit that they're suffering from those conditions and seek out help. And so we tend to have good representation of women in our studies. But where we see poorer representation is really among people of color. So we see a lot of studies that are done in predominantly white samples showing the efficacy and effectiveness of things like cognitive behavioral therapy, but we don't know if that therapy is having the same impact in terms of health outcomes for black individuals, for example, as compared to white individuals. And so where we're really taking our research at Big Health, and I think where the field is moving, is to really be intentional in making sure that study samples are diverse. And that way, not only diverse, but are representative of the population. Right. So, it's one thing to say it's a diverse, we have 5 people here, 5 people there, but no, it needs to really represent what, insomnia or anxiety looks like within the general population. And then that way we have enough of an ability analytically to look at whether there are disparities in outcomes. And that's really crucial, so that we can then go back to our actual therapeutic, or go back to our treatment or solution, and figure out what needs to change in order for this to be just as effective for women as men, or just as effective for people of color as for white individuals.
Do you think that Big Health, because you have so many users, which, by the way, do you know how many users y'all have?
So we currently cover 10 million lives in the US are covered by their employer to have access. And then we actually just, the National Health Service in Scotland actually just started covering our therapeutics for the entire population of Scotland. So that's 5 million lives in Scotland.
Wow, incredible. Do you think because you have these large data sets now, potentially you can actually even tease apart gender and sex specific, treatments that are better for women versus men, because of, the data set is based on literally the population using it rather than who we're recruiting to a study?
Yeah. And that's a really good point, is that who you're recruiting to a study is going to be different from who's going to be using something in the real world. So you really need both forms of research. The kind of lab-based clinical trial research is really efficacy, seeing does this work at all, better than a placebo. But then when you get into the real world, that's when you start looking at effectiveness and whether this works for everyone. So we've had some research done with our therapeutic Sleepio, looking at actually this particular study. It was published in Psychosomatic Medicine in 2019, looked at the use of Sleepio and its impact on depression in a large sample of patients in the Henry Ford healthcare system, and found that there were no differences in outcomes across age, sex, race, ethnicity, and education. And so that was great. We were really excited to see that. But we do have a lot of real world data. We don't actually collect information about race and ethnicity, but we do collect information about gender, I believe. And so we could look at if there are any disparities in terms of gender, in terms of outcomes, and things like that. Absolutely.
Cool project.
Yeah, absolutely. Yeah. It won't be my project, but maybe somebody will come on one day.
Some PhD student out there, reach out to Big Health.
Exactly.
Well, Juliette, this has been seriously so much fun. I can continue to talk to you. I have a lot of personal interest in mental health. I'm really open about my own PTSD and, seasons of sadness or anxiety. Yeah. And so, I mean, it's super relevant. We all have this, right? It's not like I'm being some, such a vulnerable person admitting this. It's like, no, most of us have these things.
Exactly.
Right. We have 2 last questions that our listeners really love. So the first is, we have a lot of university and graduate students and aspiring founders that listen. What's an area in women's health and wellness that still needs innovating?
Oh gosh, that's a great question. Um, I would say, I'm not going to necessarily say a therapeutic area, but I just think that there needs to be a lot more intentional attention to intersectionalities and understanding the way in which women are going to have different experiences, different stressors, different risk factors. Um, for any kind of illness, but I'll stick to mental health based on their experience of their identities. And so, really being able to take that into account when we develop interventions. I think really like the area that we need to focus on is digital therapeutics, because these are solutions that are so highly scalable, and that's what we really need at this point in our system, are scalable solutions. And so we need to really make sure that those solutions are really relevant to women by doing user research with women of all different backgrounds and who have all different kinds of intersectional identities, and also including a range of different backgrounds and identities in our research studies. So I think really here it's like we have the meat in terms of mental health, like we have the treatments that work, we have the skills that work, but how do we make sure that it's relevant for people who have these intersecting identities?
Mhm, mhm. If big health isn't asking about ethnicity or race, how are you providing different treatments because of cultural competency?
Yeah, so the way that we think about our therapeutics is that we want to make them as inclusive as possible. So right now we don't have like different versions of our therapeutics for different populations.
Okay.
We have one version, but what we're doing is more intentional user research and examining our products to make sure that they're as inclusive as possible. So include examples that are relevant to a range of different individuals. Making sure that the imagery and the what's said and all of those things is really broadly relevant and inclusive, and doesn't make anyone feel excluded or like this is not the right therapeutic for them. So that's really what we're focusing on. And we've developed a culturally responsive framework for product development to help guide us in that area.
Awesome. Sorry to have jumped back, but I had to ask that one
Problem.
question that came in my mind. The last question we have is what do you think the femtech industry as a whole needs the most right now in order to be successful?
I think, this is honestly just sort of a novice opinion, I guess I could say, but I think, more awareness around women's health and the ways in which women have really been left out of the conversation thus far. I think that if people knew more about the ways in which women have been left out of medical research, or this, like this story about Ambien, or understood that while women are experiencing the highest rates of a lot of these mental health conditions, in particular, or even other medical conditions, that they're not being included in the research or in understanding women's actual experiences with their healthcare. And so I think the more awareness we can have, the more personal stories people can share about what they've been through and what needs to change, I think pulling on that like personal experience is going to be really important in those personal stories. And I think it makes me think of the LGBTQ plus movement in terms of like the increasing acceptance of sexually diverse individuals, because everybody knows someone in their life who is LGBTQ, right? Everyone knows someone in their life who's a woman or
Mhm.
who's a girl. And so if we can create these personal stories and get them out there and massively, then I think there can be more investment and more understanding of what women are going through, and more decision to invest in making changes that are going to help women have better experiences in healthcare.
Absolutely. And not only to break stigma and potentially find solutions, but literally, if we could just talk about menstruation more in the public,
Yeah.
like, if women didn't have to hide their tampons in their sleeve, feel like they
Yep.
had to, right? Like literally just saying the word menstrual cycle, like a man mentioning periods and no one flinching,
Yep.
like
Totally.
that is a huge barrier to any of this moving forward, because we interview people about heavy menstrual bleeding and how it affects women in the workplace, because they don't want to say, hey, I just soaked through another pad, I need to get off Zoom for a second and change, right? Like men, like a lot of people aren't even knowing about women bringing extra clothes, or, their urinary incontinence. And, and it's just like, if we talked about those things, then that's like the first step towards even like talking about solutions for them, because we don't even know there's,
100%.
problems are existing. So
100%. I know. Speaking of menstrual cycles, I was talking the other day with, or no, I wasn't talking I was thinking to myself, because whenever I start my menstrual cycle, I get so exhausted. And I'm like, I need one day off a month that I get to just choose for menstrual related purposes. Cause
yeah,
yeah, but I agree. Like I'm very open talking about those kinds of things, but I think and I think that that's part of it, is like leaders talking more openly about these
yeah,
things, thought leaders talking more openly about these things. But also as a society, we need to get more comfortable talking about women's anatomy and what they go through, because like it's just natural, it's biology. There's no need to stigmatize it.
yeah.
So yeah, but it's going to be a road and a battle, but I'm willing, I'm ready for it.
You and I, here we are.
Yeah,
If you're watching this on YouTube, you'll see my virtual background is vulvas. So
I love it.
we're out here talking about it, doing the
Yes,
work. Well, Julia, thank you so much for your time today. You are amazing.
of course, no problem. It's been such a pleasure talking with you.